Thank you very much for inviting me. I'm actually fully aware that I'm on very thin ice in this room. I'm an anesthesiologist, so thank you for having me as a guest. Nevertheless, it will be hopefully very interesting to discuss these issues with you, because maybe on one or the other point, really anesthesiologists may have a different view on things that they do and that they think you should do. So probably I see some nodding already. That's your experience as well. So first of all, because we heard some beautiful lectures about how enthusiastic people are about nitrous oxide, and I'm as well actually, but however I think we have to go back and see what is evidence. Because this is what is the world today, is we want to do medicine and healthcare in an evidence-based way. So first of all, what is known and what are the news? Fortunately, there's actually a series of Cochrane reviews that really holds 255 studies and analyzed them. And actually, this is what comes out of it. There are things that, according to this Cochrane analysis, really works. Only two things, unfortunately, pass here the threshold of Cochrane. That is the epidural for analgesia, actually, and what I call from here, in here, the equimolar nitrous oxide oxygen mixture, which is the 50-50 mixture that we are talking about all the time now, which is levopan or entonox, wherever you come from. That's interesting, because there are other things that may work, how they say it. That's immersion in water, these are the relaxations, acupuncture, massage, nerve blocks, and non-opioids. All the things that you are using all the time, all the things where you could, that I don't say you shouldn't use it, of course you should. However, from the perspective of evidence-based medicine, this are only things that may work. In your hands, they do, and probably in the hands of people that combine all these things, obviously they do. And there are things, there's absolute insufficient evidence that it really works. And that is interesting. This is hypnosis, this is biofeedback, injection of sterile water, aromatherapy, TENS, and there are parenteral opioids. And I was a bit shocked actually when I read this, because there is insufficient evidence that all the parenteral opioids really work. That is not that they don't work, but the studies are lacking, right? I want to go in further detail, of course, with you, not in all of these, but what I want to highlight a bit is not epidural analgesia from the standpoint of an anesthesiologist, because it's clear. All right, it's very quiet now. The point is, we love epidural analgesia because we as anesthesiologists, we love to be involved in giving birth. However, I have to admit that usually anesthesiologists have a lot other things to do. So the increasing number of epidural analgesia is something that we are concerned of as well. The other thing, of course, is since most of anesthesiologists also have children and have experience with these kind of things, we always think, is it really a good thing to have a woman that gives birth in the moment got a big needle into the back? Well, probably not. So we have a kind of schizophrenic view on this. We love to do it, but we are happy if we don't have to. The evidence is clear. There are clear indications, and if it comes to a cesarean section, we are absolutely happy if an epidural is already in place, because we can use it safely to go on for cesarean section. There's a word probably on that. Cesarean section, ladies and gentlemen, and the higher rates of cesarean section that come up, Astrid has highlighted it very well. Cesarean section from the anesthesiologist's point of view is an anesthesia that has zero mortality. no zero mortality. There is mortality attached to cesarean sections just because of anesthesia, because we have, because of the particular pathophysiology in parturients, we have sometimes problems giving anesthesia, which is mainly hypoxia due to a difficulty or non-possible intubation, and mothers die from this. And this is the worst case. This is a catastrophe. So we would be happy if you managed, with everything that we heard, if you managed not to let it come to a cesarean section. It's always something where the pulse of an anesthesiologist rises a bit if you have things like this. So please go ahead with this, Astrid, as far as you can. I don't want to go into that anymore. I have to say a few words actually about remifentanil. Who's using remifentanil? There are a few already, right? Yeah, it's a new thing because it's known in news. These are news. Why is that? Remifentanil, this goes, yeah. Remifentanil, just short, it's an agonist, it's an opioid agonist. It's 200 times more potent than morphine. It's metabolized by hydrolysis. Its maximal effect is very, very easy to achieve within 2 to 3 minutes, and the duration of action is about 10 minutes if you stop it. There are side effects. Respiratory depression, yes, respiratory depression, hypotension, bradycardia, and all these other things that you know. Point in here is that remifentanil is really a highly potent opioid. It is used as usually patient-controlled analgesia in pumps, where it gives bolus applications, usually. But respiratory depression is really an issue. And so what are the indications? Usually where people do not want to have epidural analgesia, or if you don't want to give it, or you are not allowed to do it, so you have to think of any kind of alternatives. And so people stand up now and say, well, let's do remifentanil because it's great. It's not as great as we all thought in the beginning, really, because there are already the first case reports of dead mothers and impaired children. So if you look at the moment, and I'm not saying that these kind of things cannot be resolved, but we have to be very careful where we are today as we are in Prague in 2014. The indication in Germany for remifentanil that is written down is actually remifentanil is indicated as an analgesic during induction and maintenance of anesthesia. Remifentanil is indicated for analgesia only in mechanically ventilated patients in ICU. There's no quote about giving remifentanil to a awake patient during delivery. So if you're using remifentanil, as far as I know, this is the worldwide picture here, you are using it off-label. You have to think about this, because this is a more and more sensitive part where you are working. Even going further in Germany, it's clearly written, dosing, way, and duration of application may only be used in a working environment that is fully equipped to do everything like respiratory and cardiovascular function support and resuscitation, and only by personnel that is specially trained in doing so. So you may have to think if your working environment really can hold on to these kind of standards that are set at least here in Germany. Managing airway obstruction, assisted ventilation should be part of the training. So it should not be used as an analgesic for procedures in conscious patients. It's written in these standards. I have looked it up. Here's how they do it in a Swiss hospital. Just probably some of you know it. What they do is it's there provided by obstetricians or midwives. It can reduce pain, of course. It's indicated in coagulopathy. We heard this from the other speakers. Interesting is this thing. Do you really want to do this all the time during delivery? I don't think so. Continuous pulse oximetry all the time, right? So overall, I cannot at this time recommend using remifentanil during delivery. Let's go on to the issue of the symposium. How does that look like for nitrous oxide, oxygen things? So first, the mechanism you may already know is it's an NMDA receptor antagonism. It's well known what it is. And it also creates a central and spinal opioid liberation, endogenous opioid liberation. It is not metabolized, ladies and gentlemen. It is great because you may encounter some women that have impairments of liver or kidney function. It's not metabolized. As long as your women there do breathe and you stop giving it, they must exhale it. So the action will go away. Maximum effect 2 to 3 minutes. Duration is also just 2 to 4 minutes. We heard about this. There are side effects. I don't want to go too deep into this. Diffusion hypoxia was covered already, and the other things. Interaction with vitamin B12. Please, in some areas of this world, you may see even parturients that have an active vitamin B12 insufficiency. Think of it, especially if you have vegan persons. Vegetarian doesn't matter, but vegan may. However, of course, usually parturients are very well monitored in perspective of this, right? I want to go into some details for the rest of my lecture with you that stems actually from discussions that you may encounter if you run into an anesthesiologist in your department and they kind of tell you, you are using nitrous oxide, are you crazy? We don't do this since 10 years. So what are the arguments there? And there are always just a few that will be brought up, and I would like you to know something about this because, again, we have to look at the evidence, the scientific evidence behind these kind of things. First, I would want to show you the profile. This is a concept, actually, which is the nitrous oxide concentration here and the effect there. And if you look at this, first, you cannot give a person more than 79% nitrous oxide. Of course, the rest must be at least a bit of oxygen, right? Otherwise, people get hypoxic just by this. So if you look at this, there is such a concentration effect curve for anxiolysis. So at very low doses, you already have a good anxiolysis, which is an interesting thing that you also have and use during delivery, of course, right? The next thing is a bit of sedation, and then you have this particular curve for analgesia. So what you see is, even in low doses, you have anxiolysis that may help you over the pain, rather than really having analgesia running already. And of course, you have anesthesia, and this curve is so far to the right that it's absolutely clear that there's no way to give anesthesia only by nitrous oxide. Where are we? There are two things at the moment that you have to separate when you're talking about nitrous oxide oxygen mixtures for analgo sedation. There's one that is dental sedation. So the good news here is you're not alone using nitrous oxide oxygen mixtures. In the US, it's absolutely common that almost in every dental office you may have nitrous oxide because of dentophobia and these kind of things. And you are right here. This is the equimolar 50-50% nitrous oxide oxygen, and you see what you have. You are far away from oversedation, from all these things. This is why the other speakers clearly stated, and I can just underline this, this is a safe thing to do. And you have anxiolysis, you have a bit of sedation, but you also have analgesia. This is what we want. This is just shortly to see the two different concepts of dental sedation is a titratable inhaled anxiolysis. And of course, what you're doing is inhaled analgesic sedation, which is also used widely now in pediatrics, in dermatology, in emergency medicine. It's well established, not only for delivery. Is it safe to give this? This is the main question that an anesthesiologist will ask if he hears about that in his hospital. There are people doing it without consulting him. You can say yes. As you see, you can publish in The Lancet 2001. This is a study in 7,500 children where with these indications, nitrous oxide oxygen mixture was given. And you see the numbers. You see that there are minor adverse events in only 5% and even major adverse events only in 0.3%. This is a quite safe drug, a quite safe margin. Now, it doesn't tell you anything if I don't tell you what these minor and major adverse events are. And this is written in this paper. A typical side effects are minor adverse events: euphoria, nausea, dizziness, paresthesias. So we don't really have to worry about this too much. The only thing you have to do is get off the nitrous oxide, let them exhale a bit, and everything gonna be fine. What happened here was major adverse events, really, they saw some desaturations, airway obstruction, apnea, and all these kind of things where you could worry. However, if you look at this group a little more intense, most of these things happened in children that was less than 1 year or even 1 to 4 years, and it was not precluded to do a combination of opioids with nitrous oxide here. So I don't think that this is a big harm, 0.3%. There's even another study that is not very well known. This is this one. 35,800 data sheets with nitrous oxide oxygen. There were only 4.4% adverse events. There were 0.0% serious adverse events. And then, of course, you have to look in these kind of things. Does this patient experience the serious adverse events because of nitrous oxide or while under nitrous oxide? That may be absolutely different, right? So what were these serious adverse events associated to nitrous oxide? 0.03, 9 of 35,800 patients experienced. What are these? Well, conscious disorder, vomiting, bradycardia, vertigo, headaches, nightmares, sweating. Somnolence is even probably something that you want. So this is a safety margin where I can say, yes, I don't know a lot of drugs that have a safety margin like this. Next, we heard this already. Yes, nitrous oxide is a greenhouse gas. And we're looking more and more into this. The United States just, I think it was beginning of this week or end of last week, President Obama said now even the United States start to think of greenhouse gases. So we have to think of this. And if you hear now, I'm a green hospital, I don't use nitrous oxide anymore, challenge them, ask them. What are we talking about? These are data that you can find in the greenhouse gas inventory data of the United Nations Framework Convention on Climate Change. In short, these are the guys that made the Kyoto Protocol, right? This is the UN. You can look at these data online in a database, and what you find is these are data from Germany from 2010 here. You have a large amount of greenhouse gas that are emitted. Now you have to think, what is what? The vast majority, of course, is carbon dioxide. And there is a bit of methane, and then you have the nitrous oxide part. This nitrous oxide, so that means that nitrous oxide emissions account for about 7% of the yearly the yearly greenhouse gas emissions per year in Germany. And this is worldwide pretty much the same. The interesting thing is, the story is not finished yet. You have to think, what is this nitrous oxide? Where does it come from? It comes from other sources, agriculture, industrial process, and only anesthesia accounts for less or about 0.1%. So really, if you really want to do something against global warming, it's not using nitrous oxide, I'd rather go with your bicycle to the hospital. That's what we're talking about, right? It's all anesthesia because I think the UN doesn't know yet that midwives use it, and probably this will be different soon, or we'll just call it medical. So the greenhouse gas thing is not an issue here. And of course, there's this is the last issue that you are facing. You want to know, is it safe for me? Now, as we know, it's safe for the mothers and safe for the babies. Is it safe for me? There's always this concern about nitrous oxide and abortion rates. And this is a beautiful meta-analysis from Weimann from 1997. And goes back to the very early studies here. Actually, Knill Jones was the one that really brought it up. Probably you know these kind of things. This is the mean, and this is the standard deviation. And if the standard deviation does not reach the line of identity, that means that this is an effect to one side or the other is significant. Here, these studies say, yes, there is an increased risk, because it doesn't get to the line of identity, an increased risk of having an abortion if you are exposed to nitrous oxide. And you see all these studies. And Weimann clearly points out, if you take all these studies together, the overall, then it seems to have an effect on abortion rates. This was the big scream, right? However, if you look from what years this is, you will clearly find that these are early studies where no one looked at time-weighted average at workplaces at these times, about ventilation, about suctioning, active suctioning from nitrous oxide from there. These are studies in midwives, in dentists, in dental healthcare workers, in anesthesiologists. And how were they done? They were done with polls. They were sending out letters asking, did you work with nitrous oxide? Did you have a miscarriage? Did you have an abortion? Who's likely to answer? Yes. Unfortunately, probably the women that had an abortion and worked with nitrous oxide, right? And I don't know how many polls you get. I get things like this like every week. And of course, most of them just get to the garbage can because I don't care. So what we are talking about are preclusions that come up to this. There isn't a reporter bias. Most of them are retrospective. There's insufficient control groups. There's no data about workplace exposure limits. Probably they didn't exist in these days. And of course, there's no information in these studies about duration level of exposure. The point is that Weimann finally came out that there are only a few studies that could hold the today's scientific, are really from a scientific standard are valid, really. And these are these ones. And if you look now, none of these studies can show a significant effect. So at the end of the day, it came up here that the American Society of Anesthesiologists got a task force on trace anesthetic gases and concluded there's no evidence today for toxicity according to current scientific knowledge with regard to fertility or abortion rates. There's no teratogeneity. However, we still say no nitrous oxide sedation of or by pregnant women during the first or second trimester. And of course, this is what you would also do just to make sure. This is like the question of a pregnant woman asks you, is it safe for me to do a transatlantic flight because of the radiation? There is no evidence that this is harmful. However, who am I that I say, no, you can just go, right? So we don't do this, but there is no evidence. Last thing, time-weighted averages. Time-weighted average measure at what concentration of a respective substance acute or chronic effects on health are not to be expected. And this is on the base of a five days working week, 8 hours per day, a working life until 65. So continuous exposure to these kind of levels. This is Germany, 100 ppm nitrous oxide. US is 25 as far as I know, the NIOSH, and there are others like 80 in the Netherlands, so it varies a bit. So as long as you don't have these, you don't have to think of anything that harms you. Even in Germany, they know now that they set a little Y on to the nitrous oxide a few years ago, realizing that that a risk of fatal toxicity is not to be feared as long as exposure levels do not exceed these TWAs. So that's clear as well. Getting together. You have to think of which pain management, and we heard a lot about this, for which prurient. Side effects and safety has to be weighted from one method to the other. And the most important is who is allowed to do what, in which country, in what situation, in what work environment. And then you probably come out with this. Thank you for this.